So we're going to talk about osteoarthritis, and we're going to differentiate that from rheumatoid arthritis. So osteoarthritis is non-inflammatory. It is slow and progressive. And basically, it happens to, joints. The fluid gets lost or the joints get damaged, and basically you have bone rubbing on bone, okay? A third of adults have it, osteoarthritis, and about 80% of people greater than the age of 60 will have it. So it's very common, in our older population. Sometimes we have no idea why it happens. Primary cause, we don't know. Or it can be a secondary reason. So we actually had surgery at the joint. Maybe we had a specific trauma to that joint. Chronic steroid use. And then there's some hematological and endocrine disorders like anemia, diabetes, low estrogen. They can all cause damage to the joint for various reasons. So, like I said, for the most part, it affects weight bearing. So, hips, knees, ankles, those are the joints that are most likely affected. But let's say you were a tennis player and you played tennis your whole life, or you had surgery on your elbow, then you could get osteoarthritis in your elbow from a secondary cause. They have early morning stiffness, that crepitation. Like when you get up, I don't know, I already have this, I think. I already have osteoarthritis. I get out of bed and I'm like, oh dear God. And then you take a couple of steps and you feel super stiff until you get going. That's kind of an osteoarthritis. They have joint pain. It tends to be asymmetrical. So that's going to be a big way to differentiate this from rheumatoid arthritis, is that it only affects joints that have had the damage per se. So it might only be the right hip. It might only be the left knee. It doesn't have to be both sides. So, and you could have the right hip and the left knee for, it can be just whatever. So it just depends on what joints are affected. There's really no gender differences. Men and women get it equally. They have limited function. Yeah, and this early morning stiffness, it's kind of, have you ever heard your grandma say, there's a storm a-coming, I feel it in my elbow. This is kind of what osteoarthritis is. They can feel weather changes in their joints, those type of things. And they can get some nodes. But the big thing is that they have no systemic manifestations. It is at the joint only where the discomfort is. You won't really see this in people under the age of 40 unless they're overweight. I beg to differ. But they don't get fever, fatigue, nothing systemic. It's only the joint. And the big way we diagnose this is just history and physical. They say, I had surgery on my elbow, and now, when it's about to rain, it's sore, and in the morning, I really have to move it around a little bit for it not to hurt. So they'll give you a history. You'll do a physical exam, and that will kind of meet the picture of osteoarthritis. There's no real, they might get imaging to rule out a fracture. So if they say they have point tenderness, imaging doesn't diagnose it. It helps rule out other things. The same thing with labs. There's no labs that really diagnose osteoarthritis. We get labs to rule out rheumatoid arthritis. So we get labs to rule out other things. There is no real treatment. There's no cure. Once you have it, you have it. Basically, our job is to maintain or improve as much as we can joint function. So we want to do rest and joint protection. So let's say it's in the elbow, okay? Now, how much do you use your elbow in the morning to get ready? You brush your teeth, you brush your hair, you put your clothes on, you make your bed, you make your breakfast, you make your eggs and your coffee. I mean, you're using your elbow a lot. Someone who's got osteoarthritis in their elbow may need to get up and brush their teeth and hair and then rest. And then come back maybe 15 minutes later, half an hour later, and make their food. And then later make their bed. They kind of group their activities and give themselves periods of rest. Because if they really work it, then it gets to the point where it's too painful and they lose function of it. Same thing, like, they might have it in their hip or their leg. They can't be walking around for 4 hours and then rest. They may need to do some activity and sit and rest, and do activity and sit and rest. That helps protect the joint from getting overused when it's already not great. We alternate heat and ice. Heat helps, like I said, opens those blood vessels, bring blood to the joint, which is good because blood can be restorative. It's bringing oxygen and all of that. But if they have any, swelling from the injury, ice makes that feel good. Nutrition is important. We need to make sure they're getting things for their bones. Calcium, vitamin D, taking their vitamins, eating foods high in those items. You'd be surprised how much calcium, vitamin D women need, especially like as early as your late 20s and 30s. You need a good amount. Is that a hint that you need your calcium? Exercise. Exercise is important. So people, just because we want to rest the joints and protect the joints doesn't mean that exercise isn't important. Again, this is a lot on weight-bearing joints. So, one, exercise is going to help maintain weight. The less you weigh, the less pressure on your joints. It's just, so if you're more fit, there's less pressure. So the less pressure on those joints, the better those joints are going to feel. Also, exercise is important because it keeps you moving. It keeps things kind of limber and whatnot. But you can't be aggressive. You're not going to go out and run a marathon. They may need, swimming or biking or something not as stressful, but they still need a good source of exercise. And that's not to say that when it's really bothering them, like maybe they just overdid it one day and now their hip is really bothering them. Okay, well, let's take a couple of days off and rest it, ice it, give you some, pain control, and then once you've had that, get back to some light exercise.
So is it better to do things like non-weight-bearing exercises over the weight-bearing exercises?
Yes.
Okay.
Yeah, because they still move. You want to move the joint without hurting the joint.
It's more for flexibility rather than building the bone.
You're not building, like I said, you can't really reverse it. Once it's happened, it's happened. Because it's damaged. It's not fixable. So it's not like I get an infection, like take an antibiotic and the antibiotic goes away. I have this. I'm just trying to preserve as much function as possible. So I may not go out and walk. Maybe even walking would be okay. Depends on how the severity and where it is and all of that. But I still need to exercise it and move it and keep it moving. I just don't want to put pressure on it.
Bike ride, I think that's the best for not being weight.
Yes, bike riding, swimming. What is this?
No.
Are you sure? Are you sure?
Yes.
Are you sure? All right. Weight reduction, I already kind of talked about that. And we're going to manage pain. I'm taking this out to not confuse you. So we use Tylenol. Remember, this is a non-inflammatory process. So, something like Tylenol is sufficient to manage the pain. All right. Now let's look at rheumatoid arthritis and how that's different. With rheumatoid arthritis, this is a chronic, systemic autoimmune disorder that is related to inflammation. So OA was non-inflammatory. This is an inflammatory process. And they have periods of remission in, I always say exasperation, but I'm not exasperated. Exacerbation. I'm still saying. Did I say it right that time?
Yeah.
Okay. Exasperation.
No. That's referring.
All right. Remission and flare-ups. We're just going to go with that. I don't say breakfast right either, so.
Say what?
Breakfast.
Breakfast.
Yeah, now you're going to hear it every time I say it. I don't put a K.
Oh, like
Fast.
breakfast.
Yeah. I'll say breakfast.
Gotcha.
So, remission, now that I've recorded it, remission and flare-ups. Now you can listen to it over and over again. All right. Again, it tends to be insidious also, a slower onset. But they will have periods where they are completely fine, and then they will have periods where they are really hurting. With OA, they're kind of always at a baseline where there's something going on, right? Because it's happened. They've already got the damage is there. They've always kind of got a baseline of something going on. With RA, you've either really got it going on or they're kind of in remission right now. We don't know why it happens. We think it's some kind of combination of genetics and hormones and environment. Females get it more than males. And there is a child version of this. They used to call it JRA, juvenile rheumatoid arthritis. They call it JIA, juvenile idiopathic arthritis, just because they don't know. They wanted the title to reflect that we don't know why kids get it. When kids get it, it is a sudden onset. With adults, it's slower. When kids get it, it's a sudden onset, and they typically present at 1 to 3 years of age. So this is something that they're going to have for life. Did I answer your question? Yeah.
They have no idea what causes it.
Mm-mm. So clinical manifestations, they have non-specific ones, like fatigue and stiffness. They get systemic symptoms like fever, anorexia, weight loss. They get those kind of systemic, non-specific symptoms. They get joint pain and stiffness, and this is really severe pain. Most common are the knees and ankles, the wrists and fingers. And the pain is worse in the morning and after periods of rest. So, there's limited motion, just like OA, but the difference is there is inflammation. So with OA, when they're having I feel that, Hurricane Florence coming, their elbow might be a little swollen and it's a little, it doesn't feel comfortable to move. With someone with RA, they don't feel it because of weather or anything. They're just having this autoimmune disorder that's attacking the joint, and the joint gets red and swollen and hot. Like, you can see it. They are ginormous. Their joints get huge, and I mean, it's clearly obvious. Like, red. There's a big inflammatory process happening. And they get these rheumatoid nodules and deformities. Mm-hmm. So we do a bunch of lab work with it. We do the history and physical. Again, it's diagnosed big time because they describe, or they come in with a big red swollen knee, and they will, they'll do tests to make sure it's not like an osteomyelitis, and then they'll do some lab work, and they'll determine that it's RA. The labs they do is a rheumatoid factor. They do ESR and CRP. So ESR is your SED rate, and CRP is a C-reactive protein. They are two inflammatory markers. You will get these labs all the time. You'll see them ordered a lot. They are non-specific. They don't tell you you have RA. They just tell you that you have an inflammatory process happening. So a lot of times what they're used for is to trend the illness at the time, to see that, like, because you'll get them when you have an appendicitis, you'll get them when you have osteomyelitis, you'll get them for all sorts of different, inflammatory processes, because that's what it's showing. But they might get it because initially your CRP might be 20, which would be huge. And now, after a couple of days of treatment, your CRP is 10, and then 5, and then CRP should be 0. So they use these more to kind of trend the illness during an acute illness, to see how the inflammatory process is working. Is it getting better or worse? They can also use an ANA titer, which helps screen for autoimmune disorders. But again, it's non-specific, because you could have a lupus or whatever that also has positive ANA titers. So we use them in helping, manage treatment and helping direct care, but they're not completely conclusive of RA. There is RA criteria. Morning stiffness that's greater than an hour. So someone with osteoarthritis, they're going to get up and be like, oh gosh, my back, okay, I'm walking. After 5 or 10 minutes, they're good to go. Someone with rheumatoid arthritis is going to have it for hours. Or that swelling and redness and heat for, it could even be days, depending on the severity of it. Their joints swell in more than 3 joints. So you can have osteoarthritis just in your knee. You can have it just in your elbow. With RA, you have to have it in 3 or more joints, and they are symmetrical. So with OA, we said it would only be one, could only be one. With RA, it's both knees or both wrists or both ankles. And then the rheumatoid nodules. That's how we diagnose rheumatoid arthritis. Certain criteria.
Is that due to being systemic going through?
The nodules?
No, the bilateral.
Yeah. Mm-hmm. Yeah, because it's a systemic and it's autoimmune. The body's attacking itself. So our big goal is to decrease. Oh, I'm sorry. Yeah.
No, so recently, my nephew went to the PICU at Old Children's with respiratory distress, and they suspected it might have been the flu from his mother. When they tested my sister, she had the flu, but they said that she also tested positive for RA. Would it have been like the C-reactive proteins and all that they would have tested for when they were, or would those?
I would be surprised. For flu, they tested.
They tested for the flu, and I don't know what else they tested for because I never I heard it. Yeah, I heard it from my mother. And she said that my sister tested positive for the flu, and then she said they also tested positive for
Well, I mean, they wouldn't do a rheumatoid factor just because unless he was having joint symptoms. But they would do a CRP and SED rate. So those could be high, and maybe they said, you know, you could have some kind of autoimmune disorder like RA, or, you know, there's several others. So maybe they put that in the broad scope of differentials. But like I said, they're non-specific tests. The only one that we do that's like, it would be a rheumatoid factor test. So, which I would be surprised if they would hold that with the flu. That is not a common test we take with the flu, is a rheumatoid factor. Now, I would see them with the flu getting a SED rate and ESR, because like a white blood cell count with the differential, and getting the SED rate, even a CRP I could see, and then being elevated. But again, they're non-specific. They're going to be elevated with any inflammatory process like the flu. So maybe they're just going to continue to trend and watch, but I don't know why they would pull that. I know your situation because I happen to know your mom, but so I don't know.
Thought it was weird.
Yeah, it doesn't make sense to me.
Maybe she had joint pains and maybe she was.
She's had joint pains for a while.
Yeah.
So that's.
So our big goal is to decrease the effects of the inflammation. And we want to preserve joint function, control pain, and for kids, we still want normal growth and development. So we use NSAIDs, but in nursing, everything we do, right, we do things to help what's going on, but then also the things we do could cause more potential problems. So these people, this is a lifelong thing that they're dealing with. And so during times of flare-up, you know, they might be on NSAIDs for a long period of time. So if we're giving NSAIDs to someone all the time, what do we have to teach our patients?
With food.
Yeah, GI upset, take with food. What are they at risk for?
Bleeding.
GI bleeding. And so we need to tell them this, okay, that they're going to be at increased risk. During their times of flare-up, we rest them. We do joint protection. So if they're in the middle of like a crisis, you know, not a crisis, that's probably not the right word, but flare-up, then we're going to have them rest. They're not going to move that hot, swollen joint. And they don't like heat and cold. We want to protect against it. We don't want to bring heat. We don't want more blood flow to the area. And they don't deal well with those temperature extremes. Ice is not going to help it because ice is really not going to make things go down. The inflammatory process is happening because of that autoimmune response. We've got to kind of treat the symptoms and try to help limit the autoimmune response. That's what's going to help make their flare-up calm down. That makes sense with that? So we use things like corticosteroids. But again, so we're monitoring it. So this is what I was saying. When we're using the corticosteroids, then we're going to be looking at that CRP and SED rate. And when the corticosteroids are working, those numbers are going to be coming down. So while they don't help diagnose RA, they help showing that our treatment for RA is working against it. But again, I'm going to give corticosteroids to help with RA, but then what whole other set of problems might I be worried about? Immunosuppression,
Elevated
blood glucose levels. So if my patient's a diabetic, then I'm concerned about that, and I've got to do some extra teaching, or maybe be following up on their blood sugar levels. So again, we're not going to say to you in a test question, you know, your patient is on corticosteroids. What test will you get? No, because that's a knowledge. You guys have the knowledge. You guys have to learn to apply it, because when you're out in that clinical setting, your patients aren't going to tell you, I'm on corticosteroids. Have you checked my blood sugar? No, they're going to give you a bunch of labs, or you as the nurse, you know, they're going to give you a bunch of labs and like, which one are you worried about for your patient with rheumatoid arthritis who's currently getting corticosteroids, and the glucose of even like 150, that's going to be a red flag to you to say, I want to, monitor this. What's your action? You might have to give some insulin, or I might have to monitor blood glucose more frequently. Or if you're the nurse taking care of them and they're not getting it monitored, maybe you say to the doc, hey, did we get his blood sugar and make sure it's okay? They get on methotrexate, and that's the immunosuppressant. That's what helps kind of suppress this immune response. But again, if they're on an immunosuppressant, it's just like when we're treating them with cancer. We suppress their immune system, what are they more at risk for? Infection. So we've got to tell parents that this is not a time for your kid to be going to the park or daycare because they're at more risk of infection. We tell adults, like, be careful about your visitors and who's coming to see you. And they need a lot of psychological support. They're on multiple medications. They need multiple kind of non-farm treatments, farm treatments, and they need to understand about their medications, how to give them, what side effects to look for. Because if it's confusing to us, imagine what it is for them. All right. Everybody got the difference between OA and RA? All right, we're going to talk about club foot. Where's my baby I was using last night? So, club foot. We start going faster now, guys. I promise. We're going to zip through this. Kind of. So, club foot, it's a foot deformity. Basically, the little foot gets twisted in. And it's of various degrees. It can be a slight club foot or it can be a severe club foot. And all it is the muscles on the inside are shortened. It's kind of like, you know what a torticollis is? Yeah. With the shortened neck muscles? Same thing. It's just a shortened muscle, so it causes an ankle foot deformity. Okay? That's what it is. God bless you. That was a cute little sneeze.
I thought her desk was creepy.
Yeah. So, why? Positional. Maybe there's too many bellies in the baby, or too many babies in the belly. So they, just because of crowding, maybe you have triplets or twins, and because there's no space, and the way they're positioned, their foot just gets deformed. It can be related to a syndrome, but then you're going to see other defects or abnormalities. Or it can just be idiopathic. You could have a normal kid that has a club foot. And I shouldn't say normal, because there's really no definition of normal. I'm a good demonstration of that. So, the clinical manifestations, there's a foot-ankle deformity. How do you diagnose it? You see it. This one's hard. Sometimes when they're doing your prenatal ultrasound, they can see it on your prenatal ultrasound. But most of the time, they see it at birth. Treatment is that serial casting. So what they'll do is, like, let's say the little foot is twisted all the way in. They will pull at the foot as much as they can and then wrap it in a cast. And then they'll leave it like that for a week. So they do every 1 to 2 weeks. Then they'll cut the cast off, and then they'll twist the foot as much as they can again, and then cast it. And then leave it for 1 or 2 weeks. And then after that, they'll take the cast off and then twist it again. And they're basically stretching it. And they stretch it as much as they can, and then cast it in that stretched position. And then they continue to monitor it by doing x-rays each time they recast it. So with an x-ray. So they do this for about 12 weeks, every 1 to 2 weeks, and continue to get x-rays. And they're basically just kind of stretching it out. If they need to, they will do surgery if casting doesn't work, but that's a really last resort. Most of the time, if caught early and they do the casting, they can treat it just fine. Again, nursing care management, skin, they're in a cast for 12 weeks. So their skin gets funky, it gets dried out. You know, it's at risk for more breakdown. So we want to make sure we have really good skin care. This is done typically right at birth. So they're not really mobile. So it doesn't really affect mobilization, but it can affect neurovascular. I should say neurovascular, not just neuro. So we want to look at the 6 Ps. Again, just like we talked about everything else, check for breathing, change positions. Parents are sometimes afraid because they have these big old casts and they don't, they think their baby's broken. And you've got to teach them, like, pick your baby up, hold them, lay them on their belly, sit them up. Try to get them moving as much as you would just with, like, a normal baby. You don't want them to just have the baby sitting there all the time because they're afraid because of the cast. All right, so developmental dysplasia of the hip is basically I'm just going to say, a partial to full dislocation. Basically, that's all you need to say. Partial to full dislocation. That's what it is. So the femoral head, right here, so this is your femur, right? Your femur's in your leg. The femoral head just doesn't sit in that hip socket the right way. So it pops out of place, okay? And again, we don't know why it happens. It tends to, birth order, position, gender sometimes affects it, but we don't really know why it happens.
What was it that you said it was specifically?
That the femur, the femoral head, it doesn't sit in the hip socket the right way, so it partially or fully dislocates. And it's just because they haven't developed all the way yet. Their muscles haven't developed. Remember we talked about how bendy, Gumby like they are, and they're just not, there yet. So we have to kind of set them in place so that it doesn't keep popping out. Mm-hmm.
What does IV mean?
IU, intrauterine position. We will talk about that. So, basically, we want to look at things like the Alice sign. So we want, everything should be even, right? When I look at baby, the knees are even, the ankles are even. When I look at baby's little fat folds, they're even. Someone who has this is like the baby version of a hip fracture, right? So the Alice sign is when the fat folds, babies, they're so chunky, yummy. I love it. They're big old fat thighs. And they have those beautiful little thigh creases. They should be even on both sides. With when you have DDH, there's going to be the fat thighs or the fat rolls or whatever you want to say are going to be uneven. You're going to see the crease higher on the affected side than the unaffected side. And the same thing, the affected side, the leg is going to be shorter. So if a leg is shorter, our knee length's going to be the same? No. Our ankle length's going to be the same? No. So you're going to see, uneven lengths on everything. And they won't be able to adduct as much, bring the leg in. So the way we diagnose it, and you might do it as a baby nurse, but they do it as part of the well child check, is they take the, I don't know if everyone can see, you kind of hold underneath the hips and you hold the knees and you kind of bring the knees up and you click out and in. You probably see them do it, maybe in OB when you guys did it. They bring, and it's Barlow and Ortolani, and they bring in and out and then back in and straighten the legs. And what you'll hear is a click, or you'll feel a click, as the hip, that femoral head, is popping in and out of the socket. That's what you're feeling or hearing. So you hear that click moving in and out. That's going to show you the instability of it. So we diagnose it by the clinical manifestations. Yeah?
Do you want to feel the click?
No, that's bad. So a positive sign is a clinical manifestation that it's present. You want Ortolani and Barlow to be negative. A negative sign is good, and it's, like I said, part of a newborn assessment. If it's positive, it means that they probably have this. So we get a clinical manifestation, X-ray to confirm it, or we use our clinical manifestations to diagnose it and then get an X-ray to confirm it. And then we treat. The treatment of choice is the Pavlik harness. So that's this thing right here. I mean, come on. How cute is that little baby? All right. So it's done right at birth. They're teeny tiny. So this is when we want to treat them. Because as much as this sucks, this is way worse, right? We don't want them to be in a hip spica cast. So we treat with this little Pavlik harness, and it keeps them in that frog-like position so that it keeps the femoral head in the hip socket properly until the ligaments get strengthened and they can then move around without popping it out of its place. So they'll use this little Pavlik harness, and the child has to be less than 3 months of age in order to use it. And it's used for several months until, like I said, they heal. If the child is older or the parents are non-compliant with the Pavlik harness, then a hip spica cast comes into play. And with a hip spica cast, it is a cast, a hard cast that comes all the way up the belly. It goes down, it keeps them in that frog-like position, and it goes down both legs, typically past the knees. And all they do is cut a hole in the perineum for them to urine, for urine and poop.
So, for the,
Pavlik harness?
no, they're positive.
Or Barlow and Ortolani? Uh-huh.
So my niece actually just had surgery done. She's in a cast.
Okay.
She's 3, and they just kind of noticed when she started walking. So they never noticed when she was a baby when they were doing like the tests and stuff.
Yeah.
That can happen.
Yeah.
Obviously, but
Yeah. It doesn't, that is not ideal.
yeah.
It can yeah. Because, so that's a great example. So they missed it on, at birth. That's why your assessments are so important. Like, everyone just kind of blows through their assessments like, yeah. But you guys will catch these little things, like something minor that, like, wait a minute, that fat fold's a little higher than the other. That should be a red flag, a suspicion that that's not right. So if they don't catch it at birth and treat with that Pavlik harness, then oftentimes, especially if they're older, like a 3-year-old, they have to do surgery and put them in a spica cast. And that thing is miserable. I mean, even if you are toilet trained, now it's not like you're sitting on a toilet with a spica cast, or parents have to try to lift the child and just hover over the toilet and hope they, make it. And nothing's heavy. It's not, you're lifting up like, the child's weight, which is probably about 20, 30 pounds, plus the cast, which is another 10 to 15 pounds. So it's heavy to hold up. So they often and even as clean as you try to keep it, poop and pee is going to get on that cast and they're in it. And so it's not fun. But this is something that parents have to understand, that this Pavlik harness, they wear all the time. They don't just take it on and off when they want. They don't take it off for sleeping. They don't take it off for being held. They wear it all the time. They just take it off sometimes just to clean, like for less than an hour a day, to clean the skin underneath and move on. So,
whenever they're doing the movements, I remember my teacher, she's like, my kid was so tight that she could barely do it. Like, she's like, oh, and she freaks me out. She's like, every day you have to like do these exercises with him. Is that from this, or is that something?
That's something different. That's probably just to get the muscles strengthened or like stretched out. This, like when she's doing that, she's testing for that. But it's probably a good thing, because then they're not
so strong. You like wouldn't even let her do it.
Yeah. So remember, especially with this older child, they're immobilized. So all those complications that we talked about with immobilization, neurovascular, breathing, all of that, we have to be careful. All right, so scoliosis is next. We're moving right on. All right, so scoliosis is basically an S or C curve with a rotational deformity. Whoops. And it happens typically growth spurts. It occurs during growth spurts. Why some kids get it and some don't, we don't know. It just typically between that 10 and 13 years of age, they get that big growth spurt. So the clinical manifestations. Can I have a volunteer? Come here. Thank you, kind sir. Stand in front of all your peers. Okay. Gosh, I'm tall. All right. So clinical manifestations. We are looking at their back. Now, how many of you remember going to like gym class and like bending over and touching your toes? Yeah. All right. So that's what we're doing, the Adams test. So we're looking at the shoulders. We're making sure that they're symmetrical and even. We're going to actually feel this. Can I touch you?
Yeah.
Okay. Feel the scapula, okay? You see where my thumbs are? I'm at the bottom of his scapula. They're even, and we're going to look at, you'll see if they're a little overweight, or even if they're not, you can see creases in the side. Again, you want to make sure that they're even and symmetrical. You want to, when they're looking at the hips right here, you want to make sure, like I'm at the top of the hips, that they're even. And then, okay, now bend over and touch your toes.
That's just...
And when you're looking at the back, then you want to look in at the spine, okay? You'll either have a C curve or you can have an S curve. And what happens is when you have that curve, there's going to be rotation. Rotate, thank you, like that. All right? And you'll actually see where like the scapula is higher on one side than the other, because this is very dramatic, but because I'm making it. But you'll see that rotational curve, and you'll see one side be higher than the other. All right. Thank you. Thank you, Anna. Okay. So that's what we're talking about. We want to see that everything is symmetrical down the back, because if not, you'll see the curvature. So once we do that, that's called the Adams test, and it's checked as part of a well-child check. So when you're adolescents, when you go for your, you take your older child, like my daughter just went for her 11-year-old well-child check, and they, bent her over and checked her back and everything. It's called the Adams test. If they find anything of concern, then they will get an x-ray. And what the x-ray does is tells us the degree of curvature. And we need the degree of curvature because the degree of curvature determines what kind of treatment we're going to have. So, if it's less than 20 degrees, right, so 0 would be a straight line, right? Your spine is perfectly aligned. Everybody can have some mild curving, and that's okay. Less than 20, we just watch it. There's no treatment necessary. If it's 20 to 40, just like the Pavlik harness, they have to be in a brace. That brace is miserable, and we are talking about adolescents, okay? And they have to be in this brace for 23 hours a day. So they get fitted. There's actually a brace company that comes and measures. Did you have one?
I have it.
Oh, you have one right now?
Surgery.
Oh, okay.
My shoulders are uneven.
Oh, we'll have to. I should have used you as my Vanna.
Yeah.
Yeah.
Alright.
Do you, well, don't take your shirt off.
No,
I'll get
no,
in
I
trouble
was
with
fixing
that.
my shirt so when it bends down you could see it.
Yeah. Okay.
So my
stand-
shoulders are uneven.
all right. Stand straight.
I had,
So it's this side that's lower.
I had surgery for it, but
Yeah. Can you see? There's her one scapula, and then there's the bottom of her other one. Can you see the difference? And then you see how this shoulder is a little bit shorter, and then you don't mind bending over.
no,
in
that's
front
why I
of
was
your
fixing my shirt.
Okay. All right. So if you can see the rotate, you see how this side is more prominent than this side when she bends over. That's what we're talking about. You saw the difference between normal and abnormal. Thank you. So for 20 to 40 degrees, we brace. And like I said, this brace is miserable. They get fit. Did you wear a brace?
Only at night.
Okay. Well, they should wear it for 23 hours a day because unless you wore it after surgery. Did you wear it? No, before?
I found it in my wellness thing, and it was like 20 and 23, and then I did a brace for 6 months just at night with like bars and stuff in it,
Uh-huh.
and then it changed to like 47 and 25.
Yeah. So, and then what she's talking about is if you have a C curve, you get 1 degree of curvature. If you have an S curve, there's 2 degrees of curvature. And so they may only treat like, depending on the degree. But when you have a brace, you're supposed to wear that for 23 hours a day because it's trying to straighten you out. So how many adolescents, and again, it's fitted. They come in, they measure you, they get you your brace based on you. And then you wear this hot plastic. I mean, I sweat enough as it is in Florida. Like, I don't need any more help sweating. And I can't imagine wearing this, like, hot plastic brace around my body for 23 hours a day. The only time they're supposed to take it off is when they take a shower. I can't even imagine sleeping with it. It's got to be so uncomfortable to sleep in. You can't really move around. But the importance of it, so with how many adolescents do you think are super compliant with this? Right? They're not, But it's important that they try to be as compliant as possible because if not, if it's greater than 40 degrees, they require a spinal fusion. And it's a big surgery. And yes, it's cosmetically, it's nice to get your spine nice so you're not all crooked. But long term, imagine if you're like this all the time. You're not going to, you could get a left-sided pneumonia because your lung can't expand. You could have neurovascular damage. You can have lots of different things going on. All right, so we treat for all those reasons. So there's 2 approaches when they do the spinal fusion. They can do a posterior approach or anterior. Most of the time it's a posterior approach. Which one do they do for you? Posterior. So they lay on their face, on their front, for 8 to 10 hours. The surgery's long. It's a super long surgery. How long were you in surgery for? 8.5 hours. So they lay there like this. You can imagine all the swelling and everything else that happens. Then they make a long incision down the back, and they insert 2 metal rods along the spine to keep it in place. And then they sew them back up. And then they're in the hospital for a good week or so after. And it is super, I mean, you could tell us, it's super painful. I've taken care of lots of kids. We always get these done. Spring break, Christmas, which I always find horrendous. Can you imagine spending your Christmas break? And a lot of times it's done in summer. We see them done. Because although we need to treat them, it's not like it's emergent, and once we find it, we have to treat it the next month. We can wait a couple months. So we tend to see a lot of them over the summertime. And it takes them a long time. I mean, even like our hip fractures, we're getting up right away and walking. Our spines take, you probably didn't get up to post-op day 2 or 3. Yeah.
Yeah, I was in the ICU. So.
Yeah, they go to our ICU first, and they're on PCAs. They're on major drips, major pain drips. They are super nauseous. They often throw up. It takes them a long time to eat. Sometimes they develop an ileus, you know. So, and getting them up is a huge challenge. So the surgery is no small feat. So that's why, although this is a pain in the butt to brace, it's, you know, if not, and we lead to a greater than 40 degrees, and we're looking at a pretty big surgery. Did I describe that pretty well? Okay.
Except I don't know why I was only wearing mine at night.
Well, I don't want to speak. I don't want to.
I think they try and only do it at night because I have it too pretty severe, and I only wore mine at night when I was going through puberty, and then once my growth plates stopped, then I didn't wear it anymore.
Yeah, is there like a reason you only wear it at night?
That I would have to talk to the ortho. Like, based on standard of care.
Right.
I'm afraid to record this. 23. For your all's purpose, it's 23 hours. Now, the ortho, I mean, I'm sure, did you go to Han's group? Newstad and Han and them?
I went to one, and then I went to Dr. Joseph.
Oh, I'm not familiar with them.
Yeah.
Okay.
Joseph and Moreno, don't you?
Huh?
Joseph and Moreno.
Not as, I know of them, but I don't know them as well, so I don't
The
know
one
them.
that put me in the braces, I think.
Newstad and Han. Yeah, Newstad and Han, I know that is like their big thing is, and I've worked with them very closely, so I'm familiar with them. So they are up on the research, so maybe there's new research that says, you know, at night. But for our purposes, we're going to go with the 23 hours a day, okay? I don't want to go against your health care. I don't want to. Because I'm sure that they know the most latest research. All right. Any more questions about scoliosis? All right. So we're going to talk about 2 different bone cancers. The first one is going to be Ewing sarcoma. This bone cancer is malignant, meaning that it can, you know, metastasize to. It's a round cell tumor, and it occurs in the marrow space. So remember when we talked about, you know, the epiphysis, diaphysis? It's happening in the diaphysis, right in that marrow space, right in the center of the bone. And it grows outward from the middle of the bone. And the most common sites tend to be the femur and the pelvis. So if this is your bone, if I can draw, your tumor would kind of start like in the middle and kind of grow out like this. Okay? That's kind of how it grows. Did everyone see that? You want me to play it? Yeah, it's kind of like a hurricane, yeah. So a lot of times kids will complain. It's got an onion skin appearance. When you do an x-ray, it will look like an onion because of it grows from the middle out and it's got those layers. So it has that onion skin appearance is what we're talking about. And they can get systemic symptoms like a fever. So they'll be randomly, you know, maybe they'll have some fatigue or fever or some other night sweats, you know, some vague symptoms that indicate that something is going on in their body. But a lot of times they'll complain of just pain in the leg. And it's hard, right? Because we talked about kids and they're growing so fast, they have huge growth spurts. So it's very common, like, they'll come in and they'll be like, oh, my leg is hurting. And the parent will say, they've been complaining of leg pain for 2 weeks now. And no history of an injury, nothing going on. And you do your exam and you feel the leg and, it doesn't hurt to touch per se because there's no injury. It's just the bone hurts because there's something growing in it. So sometimes at that point they'll get an x-ray. But sometimes, that's very vague, right? How many kids complain of a random leg pain? A lot. And when you do a physical exam and there's nothing there, it doesn't warrant a high suspicion to go get an x-ray and expose the kid to radiation. So sometimes they won't do anything about it and just kind of watch it and say if they get better. Other times you'll have kids that are just like walking and the parents will be like, we were literally walking down the street and they fell to the ground. And now they won't wait there at all. Because what happens is at that point, like right here, the bone, because it's circled out, it will actually go where it just breaks the bone because the tumor from the inside just breaks it open. So they'll just be walking and then all of a sudden the parent will be like, I don't know, we were fine, everything was fine, and now they won't put any weight on their right leg. And they'll get an x-ray and they'll see the tumor in there. Huh? What? Oh, I thought you were saying
That
something.
was like a plant cracking the sidewalk.
Yeah. Oops. So they get a bunch of tests that are non-specific, like a white blood cell count will be elevated. Their SED rate, again, will be elevated. They'll do a bone marrow aspirate so that they can send it off to pathology and get the diagnosis. They can also do a surgical biopsy to help send that off to pathology. But basically, we're treating the cancer. So we treat it with radiation and chemotherapy.
Dr. Damon?
Mm-hmm.
I'm sorry, what is the FX mean under the manifestation?
Fracture. I'm sorry.
No, that's okay, thank you.
Mm-hmm. So they do intensive radiation. They do chemotherapy. So again, these kids are in the hospital, high risk of infection. They are isolated from their friends. This typically happens in adolescence that you're going to see this. So now you have this adolescent who's completely isolated, who can't have his friends visit because he's getting chemotherapy. It's just not a great situation. They try not to amputate the leg. Because again, it's typically in the femur or the pelvis, and we don't want to amputate because then that child's lost their leg for the rest of their life. So they will try to do all treatment with just chemo and radiation, maybe going in and removing just the tumor. But if it's necessary and it's, spreading or something bigger, then they might amputate. But that's not our first go-to. Osteosarcoma, on the other hand, this is the most common type of bone cancer in children, and more than half occur in the femur, but this is non-metastatic. This tends to be just in the bone, and it's near a growth plate. So unlike the Ewing sarcoma, which is right in the middle of the bone, this is near a growth plate. But so we have to be careful because if it's during a time of growth and there's a tumor there, and now that growth plate's going to be affected. Are they going to have the same growth? No. But they have really good long-term survivor rates. And again, why kids get cancer, we don't know. I don't have a why for either one of those because we don't know. And it's pretty much the same thing. The appearance is different. So the Ewing sarcoma grows from the middle of the bone out. So it looks like an onion. With this one, it's right in the middle of the bone. With the osteosarcoma, it's near the end of a bone, and it looks like a burst, like a sunburst appearance. So they look very different on x-ray too. But they kind of present the same way. You'll still have a random bone pain, maybe a pathological fracture, like they're doing something simple, like wrestling, and then they get a huge, arm fracture or something that doesn't fit the story. But just because the bone is weak in that area because of the tumor that's there, that's what causes the break. They might be limping. They might just have a limp, and the parents will be like, I don't know, there was no injury, but they've been limping for 2 weeks, and then they get an X-ray and they see the tumor, and they might have some systemic, manifestations like we talked about, the fever, the fatigue, those type of things. So it presents very similar to Ewing sarcoma, just the location is different. And like I said, this one doesn't metastasize, so they have really good long-term outcomes. We get the surgical biopsy, we might get imaging, and, cancer is its own beast. And, each cancers are approached a little bit differently and treated a little bit differently. But typically what happens is that you have an area of concern, whether it's skin cancer or a tumor in the bone or a tumor in the lungs or whatever. And they will then take a sample of that area. So they'll take a sample of the tumor from the bone, or they'll take a sample, of the skin, and they'll send that off for pathology. And pathology comes back and says, yep, it's a cancer. Once they determine, yep, it's a cancer, then we have to stage it. And it's staged like via tumor, nodes, lymph, and then, so they'll go in and remove whatever's cancerous. So for this, they'll remove the bone, the tumor in the bone. And then they'll go and again, without trying to remove the entire bone, just the part that's damaged, or just the tumor itself. And then they'll go and test the lymph nodes and see if they're involved. And then for this case, osteosarcoma, they don't need to because it really doesn't, go further. And then they'll do things like a PET scan, which scans the whole body for metastatic cells, but it's not going to catch microscopic metastatic cells. It only tests for groups of metastatic cells. So just because you get a PET scan and it's clear doesn't mean that they don't still need follow-up and those type of things. So it's hard for patients to understand. There's a lot for them, that they're going through. So emotionally, these families need a ton of support. Again, we do the limb-saving surgical procedure or limb sparing. We don't want to amputate. And a lot of times they can put a prosthetic bone in place of the tumor. So they'll take the diseased portion out and then put a prosthetic bone where that diseased portion was, so that they don't have to take the entire leg or take the entire bone. And just because they remove that portion, even if they had to amputate, that doesn't cure the cancer. And that's why I explained all those things like lymph nodes and, PET scans, because patients have to understand that they still need follow-up, they still need treatment, that just removing the tumor itself doesn't always cure the cancer. So they have to do things like chemotherapy. They might have to do radiation. They often have lots of pain management issues. And for both types of cancer, yeah.
So if it doesn't metastasize, it's still necessary to continue just because if you have cancer in your history, you'll always get checkups.
Mm-hmm. Yeah, it just makes them more susceptible. So if you have a Ewing sarcoma, it's high chance, high probability that it's, it could metastasize. So they go through all the testing, and just because the tests are negative doesn't mean that, you can never have it or it's totally gone. You have to continue to watch it. That's why you'll hear breast cancer survivors say, I'm 5 years out or 6 years. It's such a big deal for every year they're cancer free, because the longer you go without it, the better, the better outcomes it is, and chances of that you would have found something by now. Doesn't mean that it can't pop up years later, but osteosarcomas don't tend to metastasize. They tend to have very long, but are there always those outliers? Of course. So we always, err to the side of caution because of that reason. And so with both of these types, we always have to be straightforward, be super honest. Do I have cancer? Yes. Could I die? Yes. I mean, and how hard is that to tell a 15-year-old? Or tell a mom of a 4-year-old? Could my child die? Yes, they could. And you have to be honest because you can't give them false hope. You can't say, no, everything's going to be okay, and then the child dies. You have to kind of, in the most kind, caring way possible, explain to them what's going on. And that's not really easy to do. All right, home stretch, guys. Osteomyelitis. It is a severe infection in the bone. So remember earlier when I was talking about fractures and compound open fractures, this is the concern, is that on our skin we have different organisms. We have bacteria and funguses and viruses that live on our skin that are completely normal. But when we have a break in the skin, those normal bacteria that live on our skin then get inside our body. And if it's something that's related to the bone, Staph aureus can get directly inoculated into the bone and cause an infection. And with kids, remember, they're very porous and have this rich blood supply, so that makes them at a higher risk of developing the infection in the bone. Boys and people with diabetes mellitus tend to be at higher risk. I'm sorry for the boys in the room, but you tend to just be dirtier, okay? Boys tend to be more, not to say that girls aren't climbing trees and jumping off things, but boys tend to just not make the smartest choices and tend to be rougher, be outside playing. So this is why we always encourage, if kids are going to be outside playing, like in the woods or those type of things, to wear pants. It actually protects them, that if something hits them, it's a little bit of protection. Those with diabetes mellitus are at high risk because their infection, they don't have good healing, right? So if they do get cut and they do get inoculated, they just have a harder time with healing. They get both systemic and local symptoms. So systemic, again, just like we talked about, fever, pain. Local, it looks like a local cellulitis. It's tender, it's warm, it's red, there's drainage. I mean, this is pretty you guys should know this part or not. You should know what an infection looks like. I think we're good. And diagnostics. Again, we can get a white blood cell count and sed rate. They're non-specific. A high white blood cell count tells us there's an infection. The high sed rate tells us there's some kind of inflammatory process. Again, we get them so that we can monitor the progress. If we give antibiotics, what should we expect the white blood cell count to do? What? If we give antibiotics, what do we expect the white blood cell count to do? Go down, okay? Because we're showing that it's improving. But if we give antibiotics and the white blood cell count stays the same or goes up, is that a hint to us that our antibiotics aren't appropriate or it's not working for that organism? So as the nurse, this is how I'm using my knowledge and applying it to my patient, okay? For my sed rate, if I have an inflammatory process happening and I give antibiotics, what should my sed rate do then too? go down, right? Because it's saying that my infection, my inflammatory process is improving and it's going down. If it's not, this is telling me that something's not, right here. They'll do the bone biopsy so that they can see which organism it is. Most of the time it's Staph aureus. So what we'll do is, when do we get cultures? Before or after starting antibiotic therapy? Before, right? We have to get cultures before. So they'll see that it looks like an infection. Looks like an infection, we're going to treat it as an infection. So we'll biopsy the wound, we'll biopsy the area. Then we'll go ahead and start them on an antibiotic for the most common organism. And if it's not working because our labs aren't showing it or whatever, when we get our culture back, then we can then treat appropriately or say, yes, we're on the right path. They might get imaging just to look at the bone and make sure that structurally it's okay, but imaging doesn't help a whole lot in this case. They get treated with IV antibiotics for at least 6 weeks. This is the primary treatment. There is a bacterial organism that is causing this infection. We have to treat the organism. So obviously we don't want them in a hospital for 6 weeks. So we will put a PICC line in them and send them home with a home health nurse. And they'll get their antibiotic therapy at home for several weeks. Positioning, all the stuff we've been talking about. Pain meds, bed rest. If it's the lower extremity, they might be on bed rest. So we might need physical therapy to come in and work with them. Nutrition, they need lots of protein to promote healing. And they need a lot of teaching on how to take care of the wound. Because again, they're probably going to go home with a home health nurse that's going to do it. But in between, what happens if the dressing comes off in between the home health nurse coming? Or they get dirty or something like that. They've got to be taught signs and symptoms to look for. All right. Any questions? Last but not least. Woohoo! Isn't that baby cute? All right. So osteogenesis imperfecta is the brittle bone disease. Oftentimes these kids need to be ruled out for abuse.
That little.
Yeah, because what they do is they present with multiple fractures all the time.
Oh.
Yep, it's brittle bone disease. So they have very soft, pliable bones that break easily. This is inherited. They're going to inherit this from their parents. So when a mom comes in for prenatal testing, there's a certain test that they will test for. Cystic fibrosis, OI, other things. If the mom is positive, then they will test dad. And if he's positive, then there's a percentage that they can get it. So there's a lot of genetic counseling that goes in when a family has a child. Obviously, we can never tell someone not to have a child, but if the chances if mom and dad have it of them passing it on to their child, it's very high. And they don't have a good quality or quantity of life. Okay? I don't know what the exact lifespan is. Maybe your books say it, but I don't typically see them live past their 20s. Just because they die from complications, not because of the broken bones, but because of complications from the broken bones. Bless you. So they have fractures, multiple fractures. Oftentimes they get, like if you get an x-ray, you'll see fractures in various states of healing. And that's why they sometimes think abuse, because maybe for whatever reason they didn't get prenatal care, or like with everything else, this can kind of exist on a spectrum. You can have kids that are really bad, and you can have kids that are more borderline. And so maybe this was a borderline kid, and for whatever reason, because, you know, even a vaginal birth can cause multiple fractures. So if they know the baby is OI, they will schedule a C-section. But maybe the mom gave birth vaginally and the baby had a collarbone fracture, but we never really, you know, diagnosed it at first. Or they come in at day 3 and they're like, you know, the baby cries all the time and I don't know what I'm doing wrong as a mom, and they won't move their left arm, and then they get an x-ray and they're gonna, what do you think they're gonna accuse the parents of first? Abuse, right? So they'll be ruled out to make sure that there's no abuse. Or maybe by happenstance the baby was positioned wrong, you know, instead of upside down to come out, they were up, so they did the C-section and they never were at risk during birth, but then had fractures later. So that's a lot of times, like I said, they first get accused of abusing the child because they have all these fractures and multiple stages of healing. They're super flexible with their joints. They're the double jointed kids. And some other associated findings is hearing loss, and they have blue sclera, which is pretty cool, but not because of why. But diagnostics, it's genetic counts, you know, it's genetics that they do. There is no cure. So the big thing is these kids have to be handled super gently. Even diaper changes can break. The parents can be doing a diaper change and they can break the femur doing a diaper change. They can, pick up the kid too fast and break an arm. So these kids have to be handled very gently. So these are not kids that are going to be out playing contact sports. They're not your football kids. They're like your chess and piano kids. Okay? Do piano. You have to teach them how to take care of fractures, because a lot of times they're casted their arm, they're casted their legs. Sometimes they end up in wheelchairs because of it. It's just not a great quality of life because they're so fragile. And obviously, like I talked about, the parents need genetic counseling. All right. Do you guys have any other questions?
I have a question.
Yep.
The ESR, can you explain that one more time?
SED rate. It's the E, I forget what that stands for, but it's SED rate. And it's an inflammatory marker.
Okay.
So anytime there's inflammation in the body, your SED rate goes higher. Erythrocyte. That's what I thought it was, but I wasn't sure. And I don't ever want to lie to you all. So and CRP is a C-reactive protein. Again, it's just another inflammatory marker. And whenever you have some kind of inflammatory process, whether it's an infection, whether it's injury, anything, those are elevated. And what we want to see is that they trend down as we treat whatever is causing the inflammatory process. Any other questions?